there is a registry for patients who have been treated with gene therapy. And by the way, this registry also includes patients who have just been on nusinersen. But most of patients have received at one point or another the gene therapy. And the interest of registry is that yes, you are probably less precise than in a clinical trial, but you can assess populations for which you don't have data from the clinical trials. And there are two populations for which we need data for the gene therapy. The first one is the population older than 7 months, because all data so far that has been published are in patients younger than 7 months. And the second very important piece of data that we need is the safety of adding two medications together. In the real life, we as physicians are pushed by the parents to go for the extra mile, to push the envelope. And parents come to us and say, well, look, my kid is on drug A. I want him to be now on drug B, and to be on drug A plus B, whatever is A, whatever is B, because a post-symptomatic patient will never be normal, never. So the parents, as long as it's feasible to add another medication, will come and ask for it. Gene therapy got a very broad label in Europe. You can virtually give to any patients with SMA as long as they are lighter than 21 kilo, which means quite until 4 or 5 years, since these patients may have quite a low weight. Which means that there are several patients now in the real life who have been either switching, like I was on nusinersen, I receive a fix of onazamnogene abepravovec, and then I stop nusinersen. Either adding, I was on nusinersen, I got a shot of gene therapy, then I continue nusinersen. Or you can have patients who are on gene therapy, who receive the gene therapy, and then who starts getting nusinersen. So you may imagine several kind of combination. What we've learned from this poster is that actually so far it seems to be safe, in that there is no serious safety concern that came in patients who associated to drugs. And it's good to know, because of course we don't have yet the data to really say, well, this is efficient or this is not efficient. This is very preliminary data. We need to have more long-term. We don't have a comparison group, so it's just impossible from this data to be clear and say, look, there is an added value to add this medication, or there is no added value. But what we can say today is that with the data that we have collected from the real world, at least is safe. And that's important when it comes to add a medication to a 3 or 4 years old patients. The last thing you want is not to be on the safe side. So that's actually what I take from this poster. I was an author of. We can so far say that adding the medications seems to be safe with the data that we have in our hands. Doesn't mean that it's efficient, and we will need many more data for that, and a longer follow-up. That's going to be a very good reasons to come at the next WMS.